Yeah, welcome to this year's reporting from ASCO, the Congress of the American Society of Clinical Oncology. And on behalf of Mamma Mia and patients today, we're very happy that Professor Harbeck found some time to present the most relevant studies that were presented this year, and we will follow with a little discussion after the presentation. Welcome. It's great to have you here.
Thank you so much. We picked the abstracts together, and the majority of our abstracts is from the hormone receptor positive, HER2 negative sessions. And I think the advanced breast cancer was the absolute highlight this year at ASCO. There were many more practice changing news than in the early breast cancer setting. So disclaimers. So the first study we both picked is a study which addresses some medications that are not yet approved, or the new drug that is evaluated is not yet approved, but it's a quality of life study, which I always think is very important, and I'm the senior author on this publication, so I'm very proud that we were able to do this. What did we do in the EMBER-3 study? We looked at patients with ER positive, HER2 negative advanced breast cancer, and particularly those with ESR1 mutations. Those are mutations in the estrogen receptor of the tumors that make the estrogen receptor independent from estrogen. So medications that just reduce estrogen, like aromatase inhibitors, don't work in these tumors anymore because the receptor is always active, independent of whether there is estrogen available or not. So the subject matter of the study was to look at patients on progression on aromatase inhibitors, and there were three groups. Standard therapy was another aromatase inhibitor, or fulvestrant, which is a selective estrogen receptor downregulator that is given intramuscularly and is one of our standard anti-hormone therapies. And then the new medication that was evaluated is imlunestrant. That's an oral SERT, so it's like fulvestrant but as a tablet. And then there was an additional group combining this new oral SERT with abemaciclib, which is another CDK4/6 inhibitor. And again, we looked at the patient-reported outcomes, and this was done by standardized questionnaires every 8 weeks, or a weekly questionnaire for the diarrhea, and then also looking at the injection site in the muscle, because fulvestrant is giving the same day on both sides, so two injections, and so that was also recorded whether that was bothersome for the patients. And the results are that basically the quality of life stayed the same, whether it's the standard therapy or the new therapy. The new therapy did not bother the patients any more worse than the standard therapies. I think that is very important finding. And here's the efficacy of these new drugs, the oral SERT, the imlunestrant versus standard of care on the left, and then on the right-hand side, looking at imlunestrant plus the CDK4/6 inhibitor, the red curve versus imlunestrant alone. We can see that imlunestrant works better than the standard of care, but the combination works even better than imlunestrant alone. I think this is very nice. So we will hopefully have two new therapy approaches that we can use once there is a registration for this medication. And the results regarding the side effects were that 72%, so the majority of the patients, complained about injection reactions. There was some diarrhea with imlunestrant, but in the combination with abemaciclib, which is known to cause diarrhea, there was injection reactions came within the first 6 cycles. And here's a graphic from the talk by Dr. Coriano, and we can see that in the gray area, this is where the clinically meaningful changes would be. And we can see that there is some minor changes between the drugs, but nothing that exceeds the clinically meaningful spectrum. So basically, the quality of life stayed the same, although the new therapies were quite more effective. So in summary, imlunestrant is better than standard in patients with ESR1 mutations. The combination of imlunestrant and abemaciclib is even more effective, and the oral form of a SERD is more effective, but it also avoids the injection reactions that can be quite bothersome for patients. So I think this is a very interesting new drug. We hope that it will be approved soon and we can use it. For the time being, we have elacestrant, which is also an oral SERD, which is already approved in the metastatic setting. So this would be then the second oral SERD to be approved. So we have some choice um, which one to use.
Thank you very much. I think that offers a lot of new options for our patients. And especially, I think always when you have the choice between an injection and an oral therapy, I think a lot of people, it gives a lot of people a lot more freedom to have the oral therapies. And if you say that a lot of people said the injections were a bit painful, then it probably adds to quality of life tremendously.
Yeah, definitely. I think the tablets are always better than the injections. Usually, patients don't complain so about much about fulvestrant injections, but as we could see here, once you ask them specifically, obviously it is bothersome. So I think these new tablets, these oral SERDs, are a great advantage. As I said before, we already have one in clinical practice available. Elacestrant and imlunestrant would be the second one, so we're looking forward to that.
Yeah, talking about quality of life, when it says that despite a higher incidence of diarrhea, people say that their quality of life wasn't increased. Isn't that contradictory?
Yeah, but I think I mean, if you see how often patients were asked for their quality of life, it was once weekly and then every 8 weeks with the whole questionnaire. I think it's understandable that one also forgets how bothersome that is if it's a couple of days ago. So I think with these new tools like these apps like Kankado, where we can sort of record quality of life and side effects on a daily basis, I think that gives us a much better picture um, about the tolerability of these new drugs than these quality of life questionnaires.
Yeah, I think that's definitely the way forward when you say that also with the injections that wasn't reported. You know, if you asked a bit more frequently, then you get more results as well on the quality of life. So thank you very much for sharing these great insights. And we have another study.
Yeah, we have actually two major studies, and for one, we also have a little abstract on the side effects. So the Inavo 120 study is a study that we already saw a couple of while ago, and there's already a registration in the US, and the European registration is being awaited every week now because we already had a positive opinion by the EMA. So it's patients in the metastatic setting, um, progression on or after, shortly after adjuvant endocrine therapy, and the tumors have to harbor a PIK3CA mutation. Then the new drug is inavolisib, which is a PI3 kinase inhibitor. And that's combined in this study with the standard of care palbociclib plus fulvestrant. And it's a placebo-controlled trial. And the primary endpoint is PFS. And inavolisib is a selective PI3 kinase alpha inhibitor that is very specific. And because it's so specific, it also has less side effects than some other compounds that we looked at in the last couple of years. The investigators wanted to see whether inavolisib improves survival. We already know from a prior disclosure that it improves progression-free survival, but here for the first time we saw that starting early with this triplet combination of a PI3 kinase inhibitor and CDK4/6 inhibitor and endocrine therapy is actually beneficial um, for overall survival with patients with a median difference of 7 months favoring inavolisib. Also, the response rate is much higher in the inavolisib arm, and I think that is very important because a greater response rate here, meaningful difference, more than doubling the response rate in the inavolisib arm means that there's actually also better symptom control. Duration of response is also longer, as you can see on the right-hand side, with almost an 8% difference here, 8 months difference here, favoring inavolisib. And here's the overall survival data. And at every time point, starting very early, starting in the first half year, you have about 7 to 10% more patients being alive in the inavolisib arm, which clearly shows that it's really advantageous to give these drugs together early on. And if you look at the side effects, there is side effects that we expect. There is some impact on the blood sugar levels. There is about 63% of patients had hyperglycemia, and but only 7%, 6.8 to be exact, discontinued the therapy. So even though there were side effects in both arms, in the inavolisib arm, less than 10%, much less than 10% discontinued the therapy. So in summary, it's just fantastic to see this 7 months median overall survival benefit. Time to chemotherapy was pushed out by adding inavolisib right in the beginning for about 2 years, and there's very few treatment discontinuations. So my take-home message would be that this triple combination is the new therapy standard in this situation. Patients who progress very fast on or after adjuvant endocrine therapy if the tumors harbor a PIK3CA mutation. And let me just quickly go over the next abstract before we can maybe discuss this together. The next abstract was by Dr. Oliveira from Spain, looking in an earlier phase study whether inavolisib combined with several other anti-tumor agents increases blood sugar levels in a way that is not tolerable for patients who already have a high risk for developing diabetes. So there were patients in this study who were obese or had already elevated fasting glucose levels or had a pre-diabetic disposition. And then there were several agents being tested, inavolisib by itself, together with a CDK4/6 inhibitor, or just an endocrine therapy, or in the combination that was evaluated in the Inavo 120 study. And the study looked at the hyperglycemia management. It looked at the medications that were given. It looked specifically at the patients at risk and whether there was dose adjustments, like also interruptions, reductions, or discontinuations. And what the investigators saw was in this small study, less than 200 patients, 60% of them had a pre-diabetic disposition, and they could still be treated for 222 days median, so quite a lot of therapy. The cumulative dose was almost 100%, like 91%, meaning that not very many patients had to dose reduce a lot. The treatment discontinuations were mostly due to progression and only in 5.5% due to side effects, which is even less than in the Inavo 120 study. The majority of patients who needed hyperglycemia medication needed oral medication with metformin, which is a very old drug that we all know a lot about, and only very few patients needed newer anti-diabetic agents or insulin. So in conclusion, in this study that had a high proportion of patients at risk for developing diabetes, the inavolisib treatment could be done very well. There was a very low discontinuation rate to diabetes, to hyperglycemia, and only 5.5% overall to side effects. So I think This helps us in clinical practice that we can use inavolisib also in patients that are at risk for diabetes. But what we have to do is have a multidisciplinary management. So we have to get diabetes experts on board so patients have somebody to turn to if there is a more severe form of hyperglycemia. But I think overall, the inavolisib is a great step forward for our patients in the first-line setting.
Thank you very much. Well, these are great results and great options that are just uh, just published. I just wonder when it comes to the blood sugar levels, how's that administered? Because you said you that should be watched closely. Is this something that patients do by themselves, or they have to check in regularly somewhere?
Yeah, I mean, diabetes is a disease that can be managed very well in an outpatient basis. So we take advantage of all those modalities so the patients can check their blood sugar at home, and if there is a problem, then they see a diabetes expert. But I think that the low discontinuation rates in both studies, in the registration trial as well as in this side effect study, show that this was acceptable for patients to monitor their blood sugar on a regular basis. And I mean, we have a patient from one of the predecessor drugs that was not as well tolerated as inavolisib. She was like 84, 85 years old, and she measured her blood sugar every day and kept records of that. And she was very well adjusted to that. So I think it's just a matter of explanation, and the patients have to understand why they do it. But I think with a drug that improves overall survival, I think this is very easy to convince patients that that should be a good step forward.
Yeah, there's like seven extra months for overall survival, 2 years until you could postpone the chemotherapy. Then I think most people would probably say, okay, then I pick my finger once a day or however they measure it. So thank you very much for these results. And I think we have another study.
Yeah, we have one more study in the hormone receptor positive, HER2 negative space. Again, a study that focuses on ESR1 mutation, so on those tumors that get resistant to aromatase inhibitors, where the estrogen receptors work by themselves and don't care whether there's estrogen available or not. And this causes resistance to aromatase inhibitors. So this study, actually, Serena 6, was quite controversially discussed at ASCO, and because it tests a strategy change as well as a new medication. So the situation is patients are at least 6 months on their first-line therapy with aromatase inhibitor and CDK4/6 inhibitor, and then they get regular measurements of ESR1 ctDNA in the blood. And if ESR1 mutations pop up, we call that molecular progression. And the molecular progression is there before there is a clinical progression that we can detect by imaging. So, to just explain what that means in everyday clinical practice, there was over 3,000 patients being tested for ESR1 mutations in their blood every 2 to 3 months. There was a mutation found in 548 patients, and in half of them at the first test result. And then 233 of these 548 patients were not available for the study, and the majority of them because there was clinical progression. So once we saw the ESR1 mutations in the blood, there was already progression seen on imaging. But the remaining patients were randomized to switch to a new therapy, an oral SERD, like I explained before, camizestrant in this case, and continue the CDK4/6 inhibitor. And the control arm was just to continue the therapy because it hadn't led to clinically overt progression. So the result was positive. If you change early because there's this molecular progression, you actually have a longer progression-free survival. And that is very meaningful with 16 months compared to 9.2 months median hazard ratio 0.44. And also the PFS2, so the progression-free survival after the next therapy post-study was significantly longer in the camizestrant arm. Here's the curves. We see the green curve with changing to this oral SERD. Camizestrant is beneficial for patients all along, and the curve split very, very early already. And so the results summary is that this was well tolerated. There weren't any unusual side effects. There was some photopsia, which is light flashes at the edge of the vision field, which are short, reversible, and according to the authors, not correlated with any structural eye damage. And there is very little treatment discontinuation. So, in summary, camizestrant plus CDK4/6 led to a clinically meaningful, statistically significant improvement in progression-free survival. And SERENA-6 is the first registration trial that actually shows that it's useful to look at these ctDNA changes early and overcome resistance by changing to a new medication. And my takeaway is that this is indeed an innovative trial design, but it tests too much to interpret properly. It tests a treatment strategy, a testing strategy, as well as a new drug. And we know from the trial that camizestrant is effective in these ESR1 mutated tumors. But to see whether this strategy is actually ready for prime time so we can do it in the clinic all the time, we need to see that patients live longer if we change the therapy early. And just to illustrate the discussion we had at ASCO, I took one slide from the discussion talk by Dr. De Michele, and what she showed, and I think that makes it very clear, is that the trial actually lacks one arm. It lacks the arm that we continue the standard of care therapy until there is symptoms or radiological progression, and then add camizestrant plus a CDK4/6 inhibitor and see how long patients benefit from that. And we don't have that arm, so we just have to assume that it's better to change early, but we don't have any proof. Though I think before this will become something that we need to do in all patients, we need to see more follow-up data and see that that actually also affects long-term outcome, that if we change the therapy early. And I think that was one of the major criticisms of this trial. But overall, I think it would be nice to have another oral SERD available, registered, because it's effective in ESR1 mutated tumors. So I'm looking forward to that.
Well, thank you very much for again these breaking news. And again, we are approaching a level where it's more and more individual approaches. So I was just wondering, this probably emphasizes the importance of testing, or is this the wrong message to everybody to select test, 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 test? What do you say?
Well, first of all, this is not approved yet. So this strategy, as well as the new compound, is not approved, and we have to just wait and see what the regulators say. So far, we can test twice a year for ESR1 mutations, and we test for them every time the old therapy doesn't work anymore, just to make sure that we don't overlook an ESR1 mutation, because we have an approved drug, elacestrant, that already works in that setting. So we're basically checking for ESR1 mutations, but we don't check every 2 to 3 months. And I'm not sure that that is the right strategy forward for every patient. I would like to see more mature follow-up data from the SERENA-6 trial to give us a hint whether that actually makes patients live longer without chemotherapy, or just helps them live longer overall if we change therapies early. And so far, we don't know that.
Well, then it will be interesting to see if you say that there's already more data expected this year and on several trials. It's progressing very, very fast at the moment, and it's very promising. So thank you very much. Yeah, that was one of our takes from the ASCO, and it's my part to thank Professor Harbeck for your time and patience to explain everything to us and discuss this with me. I look forward to our next take.
Thank you.